Thank you, Bill, and thank you so much for the opportunity to add this panel discussion to close out this wonderful symposium on why we need a private sector access strategy for quality diagnostics. So an obvious question to many of us who work in countries like India and Pakistan but it's not so obvious to a lot of other people. So why do we even need worry about the private sector? Out of the 22 highest TB burden countries in the world, there are at least 12 with massive dominant private sectors. And I've listed those countries to you. In these countries, more than 50% of primary healthcare visits are to one or more different types of private healthcare providers, okay? So India and Pakistan are easily the top two. And in countries like India and Pakistan, 80% of anybody for any healthcare will first go to the private sector provider, not to the free public health service in these countries. So that itself is food for thought, how dominant private sector is in many countries. So here's a startling number that Puneet once told me, and it stuck in my head. So out of every 4 TB patients on this planet, one of them is an Indian. Out of every TB patient, out of every 8 TB patients on this planet, one is a privately treated Indian patient, okay? That's because half of Indian TB patients are in the private sector. So that's 1 in 4 becomes 1 in 8. So that's why this is so important. Secondly, look at the data. This is from India, and I asked a similar question to Amir Khan right now. 70% of TB patients in Mumbai had first sought care in the private sector. This is data from FMR. 94% of TB patients in Patna city first sought care in the private sector. And Amir just told me 70% of Pakistani TB patients began their journey or pathway to care in the private sector. And what happens in the private sector? They get bounced around many, many times before TB gets picked up. An average Indian TB patient who starts off primarily in the private sector is diagnosed after 2 months and after having seen 3 different doctors before TB gets picked up. Just do the mental math on how much transmission could be happening at the level of primary care when they're bounced around from one doctor to another before TB gets picked up. And this is the crazy part. On one hand, private-public is very black and white for us, right? If you go to the FIND website, you will see who is eligible for FIND pricing. It's very clear, private-public. But for a patient doesn't care about FIND or access pricing. They go and they bounce around between private and public. They could well start off with a pharmacist. Then they could go to an informal provider. Then they're not well. They go to the public sector. Then they're disillusioned. Then they come back to the private sector. And you ask practitioners like Zarir Udwadia here, I bet you people have bounced around all of these people before they end up with someone like Zarir. So that's the point we're trying to make. This watertight compartments do not make sense at the practitioner level. And here's the funny part. Even the doctor spends morning in the public sector and evening in the private sector. So both doctors and patients do not respect these public-private boundaries. We need to think of the entire country and the TB problem for the country, not so much that only public matters and private doesn't matter. So that's another reason to worry about the public sector. The good news, which all of us know, is that we now have wonderful tools. There's no rationale why we shouldn't be rolling them up across the whole country. The bad news, and this really gets me upset, and I've expressed this unhappiness to FIND 500 times already, Claudia's getting nervous now, is that private sector is consistently excluded from every single pricing agreement. Hein, Midget, anything that has ever come out for the WHO stable, private sectors constantly get bumped off. You could be the poorest private patient in India, and you do not have access to quality diagnostics or any of this pricing scheme, which is a real tragedy in my opinion, because I've just shown you how important this segment is, and there's no reason to deny them. In fact, what happens, private sector is excluded, so the companies, and all of them are in this room, invariably will have distributors in countries like India or Pakistan or Bangladesh, and look at the price inflation, guys. This is just staggering, right? This is data from CHAI, and you see the cartridge itself is priced higher in India in the private sector, and then the distributor, there's an import duty into India or Pakistan or Bangladesh, there's a distributor margin, and there's reference lab margin if it's a network, there's a franchisee lab margin, and there's providers who get incentives out of it. That's how your $20 cartridge ends up becoming a $70 assay, right? Now, who can afford a $70 gene expert in Bangladesh or Pakistan in the private sector? Why does that matter? Look at the actual data from 12 countries now. So we did a survey done by a student of mine working with the FIND team as well. So all we did was contact our friends in 12 of the most privatized of the 22 high burden countries, and we asked them simple question: do you even have gene expert in your private market? Is it even available? If it is, what is the patient paying for a gene expert test in your country? And this is data that many of you have contributed to, and I will make this very simple for you. In 6 out of the 12 highly privatized countries, there is no gene expert at all in the private market. You either get it in the public system or you have nothing, okay? And those are Uganda, Vietnam, Indonesia, Myanmar, Nigeria, and Cambodia have no private sector commercial gene expert sale. There is no market, okay? Of the remaining, Kenya, India, Pakistan, Philippines, Bangladesh, and Afghanistan, only India has at least some reasonable number of labs, 76 and 60, and I'll tell you more about why they are two different numbers. The remaining, look at that. Kenya has only 5 private sector labs. Pakistan has 4. Philippines has 11. Bangladesh has 4. Afghanistan has 1. The entire country has 1 private gene expert installation. So you can already see, because of this pricing and all of the market-related issues I've told about, gene expert is just not commercially available in half of the privatized countries, and the remaining, it's available, limited in most cases. India is the only one which has at least reasonable numbers, and look at the price. An average person is paying $50, $60, $70, and with Philippines maxing out at $150 per gene expert in the private sector. The lowest price we found in the entire world in the private sector is this. This is in India through an initiative called IPACT, which Harkesh will tell us more about it. The next lowest was Pakistan. These were the only ones, and the lowest was $30. $30 is the lowest price anyone in the world can pay for in the private sector, and that's in IPACT, okay? So can TB patients afford these prices? So this is again data from Chai from India, but I bet you it's no different in any other country. Just because they're private, do not assume that these are rich people, okay? Yes, there are rich people in India, okay? And Amitabh Bachchan also had TB. We're not talking about Amitabh Bachchan here, okay? Most people do not have that kind of money. Their entire household income, even if you spend half of a household income, they cannot barely, only 4% can afford this test in India at the price that I've given you, right? So this is so important that TB patient requires a different type of a market approach because these are predominantly poor people. Yes, they are very, very rich people. They can also get TB. That's not the group we're talking about here. Okay? So the key findings of our study was commercial private sector sale of gene expert is very limited in many HPDCs. I bet you it's the same for Hein, it's the same for liquid culture, it's the same for all the WHO endorsed tests. Barring some exceptions, patients in the private sector pay a lot for gene expert, same for Hein, same for midget, same for anything else that will come through the pipeline. This translates into low level of access to quality tests and can completely blunt the impact of new diagnostics in these markets. And do we care about these people? We really need to care about them. Why? This is a mathematical model that David Dowdy, who was here, and his team did with us. And we looked at it and say, when do you have access, impact in a country like India on incidence, prevalence, and MDR? When you only make gene expert available in the public sector only as a DST tool, impact is the least. As you keep expanding gene expert to the private sector and the first contact provider, that's where you get the maximum impact, because patients often go there first. They come to the public sector last. So putting it as a last technology doesn't quite give you much impact in terms of transmission. So if we care about early and accurate TB diagnosis, if we care about universal DST, then we need a private sector access strategy. We cannot ignore this many people and exclude them from the good tools that we have in our armamentarium. So with that, I'll now invite our panelists, Harkesh Dabas from Chai, Sanjay Sarin from FIND India, Renuka Gadde from BD, Janet Ginnard is not Chai, she's United, Amir Khan from IRD Pakistan, and Dr. Sunil Kapade from RNTCP India. So I know all of them, which gives me a license to ask them some really hard questions, right? And get away with it, okay? So I want to kick off by asking, I have a lot of questions. We'll see how much we can get through. Claudia, give me a signal on when we are close, and then I'll try and wrap up, okay? So the first question is for Sanjay. Right now, you have a mic, Sanjay? Okay. So I know historically how and why FIND chose to focus on the public NTP sector, which still is a huge part of your strategy. But can we, at least for the future technologies, reconsider the decision to exclude private sector from the FIND negotiated, subsidized, concessionary pricing? Is that possible? Two, I know FIND strategy is out there. There's been a lot of rethinking in FIND on what your strategic directions are. Where and how do you see private sector fitting into your strategic thinking right now?
Well, thanks, Madhu. Thanks for the opportunity. So addressing the first question, that is, can FIND include the private sector as a part of its pricing strategy? So on the face of it, yes, it makes perfect sense. I think you showed some slides, and this is not new data. 60 to 70% of the patients accessing TB diagnostics in the private sector, it makes perfect sense to extend the pricing to the private sector. But having said that, I think pricing alone is not going to solve the problem. And you need to look at it from different aspects. For example, if you were to extend the pricing benefit to the private sector, from a manufacturer's standpoint, they need to take these volumes, or the patients who are getting tested in the private sector, while making the pricing decisions. Because pricing, after all, is what we are talking about, and there is only so much that we can do in terms of even giving public sector pricing to the private sector. Because I remember from my days in the private sector, and I was working with BD for almost 9 years, even in countries where there was FIND pricing available to the private sector, because of the additional levies like the distributor margin, the transportation costs, and whereas freight costs from X factory to the country, and the local distribution costs, the prices were really getting ballooned up. So that's another area which needs to be looked at. So from a manufacturer's standpoint, they really need to consider the volumes of the testing that is happening in the private sector while making the pricing decisions, and if that can move the global volumes, and definitely achieve a lower pricing. I think the second aspect is when you speak to the private sector, and having worked with the private sector for almost 18 years, selling TB to the private sector, it's a hard sell. It is just not there in their priority areas. They'd rather invest money into the tumor markers and the more esoteric tests because there are bigger margins there.
Absolutely.
And I think that's an irony when you look at specifically the Asia Pacific, where you have the bulk of the TB patients. And despite that, there is a lack of realization in the private sector that there is a huge opportunity sitting. But I think it is also upon entities like FIND and the other partners who are sharing the panel and the dais with me to make this case with the private sector that what is in it for them. I was hearing Mario in the WHO session, and he said that every dollar that you invest for TB, there is a return of almost $40. Now, I think that's great. That makes great sense from a public sector, because as you were talking in terms of lives saved, but when the private sector comes in, they're really looking at it from a dollar standpoint.
What's in it for me?
What is in it for us? So I think that's another concern that needs to be addressed. Maybe talking to the C-suite guys, and the other aspect is, and I think I'm sure Harkesh would be able to better allude to that. Mechanisms like IPAC, they're great in terms of reducing the pricing to a certain extent. But I think looking at countries like India, where you have more than 100,000 laboratories, and tomorrow if you have more and more labs going on for these WHO-approved diagnostics at access pricing, where is the mechanism to monitor that these labs are offering these tests to the patients at the ceiling price? And I think we need to really look at that mechanism. Otherwise, the entire exercise of working with the manufacturers and bringing down the prices will just go for a toss.
Okay.
And I think the third aspect here, I believe the government also has a role to play here. And as I said, there are levies like the customs. For example, in India, you pay almost 26 to 28% duty on both the instruments as well as the reagents. And I'm pretty sure, I think, and probably Renuka will talk about it, that the manufacturers would be willing to pass on that benefit if that duty is waived off. HIV, for example, doesn't attract any duty in countries like India, and if that benefit is even given to the TB diagnostic manufacturers, I think that 26 to 28%
price reduction can go to the patient. Can you address Fine's thinking on private sector?
So as I said, we fully understand the importance of the private sector in terms of increasing access to the new technologies as far as TB diagnostics is concerned and otherwise. And we are actively looking at effective ways and means of engaging the private sector. In fact, Bill, he showed a slide as far as one of the projects that we are running in India on pediatric TB diagnosis. So here there is already a large private sector component. So just a quick bit, this project basically is about offering upfront expert testing to the pediatric TB suspects in both the pulmonary and the extrapulmonary samples. And we are not only working very closely with the KOLs and the providers in the public sector, but are also actively coordinating with the private sector to drive the referrals. And this project is being implemented in 4 cities right now, and we are looking at further extending the project to make it a total of 9 cities. So yes, there is a thought. One last point I wanted to make about this, I think given, it makes perfect sense for Fine to look at the private sector. Given our expertise, our track record and experience, and our deep understanding of the country healthcare systems and our relationships with the governments, I think we can partner with the private sector to really help them shape their market access strategy.
At the very least, we should help increase notifications from the private sector to the program. That would be an immediate, tangible benefit, as we will come to Dr. Kapade in a minute. So Renuka, I have 2 questions for you. One is, you were one of the first, in fact, you were the first company to have a special Fine negotiated pricing for midget in 2007. And kind of everybody else followed along, Hein and GeneXpert. I know at that point in time, we probably weren't thinking about access to the private sector for liquid cultures, but today we now kind of realize how important that group is for MDR-TB, for example, right? Huge number of MDR-TB patients are managed in the private sector in India. So going forwards in future, how challenging would it be to convince manufacturers like you to also keep private sector? In other words, if a pricing agreement is done, it's done for the whole country. All of India gets that price, all of Pakistan gets the price, all of Kenya, Nigeria gets the price. Is that still very difficult, or you still believe in stratifying by this public-private, even after everything that you know is true on how patients behave and how doctors behave?
Okay. So Madhu, in an ideal world, you'd want an Amazon.com pricing for everyone and just order it off, right? So let me just respond to your question with some color, some background. The slides that you showed are very compelling. And when you talk about private care treatment in India, there's a formal private sector, as you noted, and there's an informal private sector, as you noted. And the hard reality today is that informal private sector in most countries where they exist are not truly recognized or embraced by the government. You want them, but you don't want to give them the whole, embrace them as the medical community. So therein lies a bigger problem. So which private sector are you referring to, right? The trained, formal, or the unqualified, informal? Are you doing more harm, more good? What's the balance there? So there's a larger system than pricing that needs to be addressed here. Coming to Fine pricing and midget pricing, specifically to TB, I think I'm the only manufacturer here on the panel, but I think I'm speaking for my colleagues in the industry. When you take a disease such as tuberculosis, which is, as you also noted, not necessarily the disease of the affluent, and it really impacts those who are in deep poverty, I don't think any company here will sit and say, no, I want to make money out of it. So that's kind of one statement. Having said that, I think you really have to have a sustainable strategy. The more you give away, the less there is to innovate, and the more demands then in you're not successful, right? I think there was some recent discussion as to how R&D investments in TB really don't take off. And there's going to be a congressional hearing in Washington next week to really champion and mobilize funding for TB to make it attractive enough, right? And so all of these are larger than manufacturers pricing their project. Interesting, when you approached me on IPAC, and I remember the conversation very distinctly, I love the whole initiative. We've had several conversations with Harkesh and Sanjay at that point. And oddly enough, we found that we actually give them fine pricing anyway. So what else could we do? We were already there because in a condition like TB, you're not looking at making your normal. So there is a market dynamics which no one should disrupt. It's for the benefit of the whole country, the disease state, the industry, the stakeholders. But there are compelling public health needs where companies will not be shy. You talk about the assured pricing strategy now, assured criteria for POC. Every company is looking in at affordability right upfront in product development. So Midget was developed at a point in time when no one even conceived would become a reality of the developing world at a point when it was developed, right? And you're still making that access possible. So all new technologies consider affordability, but I think the real challenge in this situation is the larger ecosystem, regulatory environments, which really add up to the cost. Customs duty, as Sanjay said, the formal recognition of the informal private sector, volumes, all of that come into play, but I don't think any manufacturer here will sit and say, no, I want a profit at the cost of TB.
That's a great point. Can I just ask you to comment on this particular issue? So what happens if you didn't think about subsidized pricing is if you end up with something like this, that your product is completely absent in some really big markets, potential markets, and of the ones that you do have, you end up with pricing where I'm sure the numbers will be so low. In other words, your product isn't really having much of a traction in those markets anyway, which is probably why we've managed to get IPACT in place in the first place, because now at least you have a shot at increasing your market penetration, because otherwise the private sector is just not able to afford the test as it stands with the regular pricing. So maybe something like this is a little bit more convincing than just the argument that private TB patients also need good quality tests.
Right, and I think it's all a question of market dynamics. If you look at the TB particularly, Madhu, I believe it's the single largest disease state which depends solely on one international funder, global fund. Not that countries don't put in their money, ministries of health contribute their function, but the external funding and dependency is so large that there has to be a large mobilization of government's commitment as well. So just to say, as a company for profit, I sit on the Global Fund Private Sector Delegation, and we've been championing forever a Global Fund proposal to actually address private sector needs, working in with FIND in Geneva with the Stop TB folks in Geneva, to say, why don't we create a programmatic response to once and for all address the private sector needs? So I agree that there has to be buy-in, it has to be a public and private collaboration. It's not about private sector alone. Many actors need to come to solve this complex maze.
Thank you, Renuka. So Harkesh, you have a mic. So can you tell us, tell the audience how on earth we managed to get the price of GeneXpert to $30 in the Indian private market?
And thanks, Madhu. I think it would be appropriate to first just give a brief background on what IPACT is. IPACT stands for Initiative for Promotion of Quality TB Diagnostics in the Private Sector. And how IPACT sort of came about, just a brief background of that as well. As Madhu said, 80% of people in India first seek healthcare in the private sector, A. India carries 24% or 1/4 of the TB burden, and therefore that's a large number of people who go and seek care in the private sector. Where do they go in the private sector? They would go to about 800,000 odd qualified providers, about 600,000 providers who principally practice traditional systems of Indian medicine, or about 1 million or 1.5 million informal providers who have no formal qualification. Or they could also go to about 800,000 odd chemists or pharmacies that dispense medicines. And after bouncing around in the system, if they do manage to get a prescription for a test, they would go anywhere to 100,000 odd laboratories that Sanjay referred to. And therefore, that's a large ecosystem in the private sector that we are talking about. And when we started looking at it, we found that there was really no uptake of quality TB diagnostics in the private sector. I remember early days with Martin, I used to ask him, so how many gene experts are being done? And he used to embarrassingly at that point in time said, well, it's not a number to be talked about or not to be mentioned. And so it was less than about 2,000 till 2012. So less than 2,000 gene experts in the entire private sector that caters to a market of anywhere between 1 to 1.5 million patients. The number of presumptive TB cases obviously is much higher. And when we looked into the problem further, we found that, well, the value chain that delivers this particular test to the patient is really long, and Madhu showed that slide. It starts with, it's a really long value chain that, with everyone's margin accounted for, you end up with a pricing which is in excess of $70 odd, both for this as well as for a gene expert, for Hain LPA, as also for the midget culture. And clearly, A, there was a market need. B, that need wasn't being met. C, there was a business case, but no one was recognizing that business case simply because they're not seeing the volumes up front, and therefore saying, well, we have our fixed costs which have to amortize over a very small base, and therefore the price has to be higher. And what we really did was gather a few large champions, large laboratories that are principally, they are laboratory chains that are spread across India, and spoke to them about the need to go from a high margin, low volume business to a low margin, high volume business. And we found that, Martin, who championed this for us in Cepheid, similarly Hain LPA as well as Renuka in BD, that they were happy going to that business model, but as long as Sareen said, that someone needs to ensure that pricing benefit is eventually passed to patient. And therefore, that's how we sort of came up on a model where we said we need to get the suppliers or the manufacturers into this, we need to get the private providers, the laboratories into this, and we need to get the National TB program into this, and then see whether we can structure a win-win-win across everyone. And that's what really happened. Everyone wanted to do it. All it needed was someone to catalyze this. Today, from the 5 early laboratories that we started with, we've now gone to about 120 odd laboratories that account for about 6,000 odd collection centers spread across 85% of India. IPACT, the price has come down from $70 to $30. It's a fixed price, we monitor it. The leadership of this is a program that's managed by the laboratories themselves with very little support from CHAI. The volumes have obviously gone up from less than 2,000 I alluded to previously. It's about 250,000 tests that have been done. And the program is growing as we go along. Is there applicability of this to other countries with high burden? Absolutely. As long as there are few things that you keep in mind. A, that it has to be rooted in business, some kind of an existing business dynamics. You can throw money at a problem only for a short time, but for any initiative to be sustainable, it certainly has to find a business case. B, you have to structure it as a win-win-win for everyone involved. In this case, suppliers benefit simply because they're seeing higher volumes now. Laboratories benefit because they are seeing higher volumes now. CHAI and other non-profits benefit because that's what we want to do. The National TB program, and that's another thing, stewardship and guidance of the National TB program is absolutely, absolutely essential. And we found that, the program saying, let's get this done and please go ahead. And being an active partner and guide in that entire process. And, we had that in the National TB program. Then you also need a few mentors who will keep you awake at night from halfway across the world, which was Madhu, who just keeps writing to you every now and then, making sure that you're staying on track. And finally, as you know, as Wendy had said in her this thing, you need a multidisciplinary team, a young and energetic team. I had a team of 3 that made it possible, and I think Karthik is somewhere here. He's lived out of a suitcase for last about a year and a half, and he's made this possible. So yes, absolutely feasible to actually implement this in countries where similar dynamics exist. It has to be contextualized, of course, and B, you need resources to get this done. These are high transaction costs. Going and engaging with 100 different laboratories, getting them to buy into the business model, convincing them of the business case, making sure that it's thereafter running, making sure that they're sticking to the ceiling price. That's high transaction cost, and a team of 3 has got it done. They of course have 48-hour days, but that's how they did it. I was looking at the list and I saw that most of the countries, I think it is doable, but as long as you meet certain concepts.
And you need a coordinating group to pull it off.
Absolutely.
So it may be worth telling the audience that even with the $30 per gene expert price, there is still a profit margin. So none of the private labs are losing money. So there's still, how much is the margin that they still have, Harkesh? About 30% or so?
Yeah, but $6 is
So they still are making money. It's not as if we ask them to do charity. So that's an important decision-making. Thanks a lot, Harkesh. Can we now ask Dr. Kaperde, who's the TB program manager of India, to tell us a little bit more about, we just came here from the PPM core group meeting. What India has now done, and dramatically, this was in the WHO report this year, dramatically increased the number of private sector notifications. I bet IPACT contributed to that with the lab notification. So privately managed patients in some cities can get free TB drugs from the program. So similarly, can privately managed TB patients also get free WHO-approved diagnostics from the program? If yes, what are the mechanisms for doing that? So in other words, they still keep the patient, they're not referring away, but still get access to diagnostics.
Thank you, Dr. Madhu. Let me start first with India is, you know very well, that is a high burden city, a high burden country as far as TB, HIV and MDR TB is concerned. But we may be having the highest number of cases in the world. But at the same time, I would like to say it is because of the population, our prevalence is not very high as compared to other part of the country itself. It is only because of high population, second most population country in the world, and that's why this particular aggregate rate is very high. At the same time, I just would like to say the 1 million cases which is missing in India, these are the priority for me actually as a program officer, because these 1 million population is a mainly vulnerable population, those who are below the socioeconomic factors, they are having the below poverty line, or they are the vulnerable, they are migrant, laborer, and these population mainly transmit the disease. And how to make them, because these are the patients who are not only reporting to the RNTCP through our notification, but at the same time they are spreading the disease in the community itself, and that is the main cause of the transmission of the disease in the country itself. And these particular population, if we want to have, how we can just make a diagnostic accessibility to them. That is a very important priority for us. Because the patient who are coming to the hospitals or patient coming to the private doctors, they are just getting the treatment and all these things. Second, my problem is that about unregulatory private sector. The unregulated private sector means they are not following the diagnostic protocol or treatment protocol, what we are expecting or what the government or what the standard for TB care is mentioned in that protocol. This is also one of the cause of reason for the MDR TB as well, because the patient are missing, patient are not regulating, patient are not getting the proper treatment, inadequate treatment, because they are not. So for that we require, and more than 50%, 1.5 million out of total cases, we are not are taking the treatment in the private sector itself. Means more than 50% are taking the treatment in the private sector. So we have to see how this particular private sector should be accessible for the diagnostic services to the poor people. And third is important is that TB is, as you know, the social pathology of the TB. TB is mainly causing to those socially, economically vulnerable population. I mean, it may be cost to anybody in rich and poor, but mostly if you see the vulnerability is toward this population. In such situation, how we can go for a business model, how we can just see that private sectors can be involved, and how we can just give the universal access for a quality diagnostic services to the each and every population of this particular country. That is one of the main objective of our universal access to the TB itself. So what I just want to, we have already done some of the PPM studies or PPM models where we have seen that how the private sector can be engaged for the diagnostic purpose. We have seen that in one of the projects which is already been told and presented is a pediatrics TB, where the 4 major cities, pediatricians have been mapped, they have been trained, and they have been given the institutional training itself. And also they were asked that after, and CBNet was made upfront for this particular thing, because the diagnostic challenge is always there in pediatric TB. And that's why this particular CBNet, when we make upfront, we have seen a lot of field which we would not get by the simple microscopic test. About 20% of the positivity rate was found by CBNet itself when we are just done in this pediatric ward. This is the one way we have to just see that how sensitize the private sectors and bring them in the fold. And that was the one of the reason why we are making the policy of upfronting the TB, upfronting a CBNet in the pediatrics patient and extrapulmonary TB cases and also in the HIV TB cases. Well, this is one of the example I'm taking. Second example is the IPAC. IPAC is one of the good example where the negotiation with the manufacturer, we have to make it by the third party, and this should bring down the cost and subsidize the cost, because most of the 50 to 60% of the patients are going to the private sector and they are not very rich, they are very poor. In spite of that, a behavioral pattern is there in India that, okay, they will go to the private sector, we can't, well, they are going to the private sector, nobody can say that.
Thank
So
you. Dr. Kapade, in addition to IPAC and the project that you mentioned, there may be another really important regulatory change that can be made that will benefit a lot of the WHO-approved tests at the same time. It's this discussion of, could the Indian government make all WHO TB tests duty-free, just like HIV diagnostics? You came from NACO, so you are aware that HIV products are all duty exempt, and it makes no sense that TB, being such a big killer in India, should still be on the duty list. So that may be a simple change, but it could easily bring down the price by 30% or so across the board for only WHO-approved tests. Is that possible?
Yeah, why not? We can just do in that particular way, because in HIV/AIDS we have done the same thing. And in TB also, we can just move this particular moment, and we can just start at how we can just reduce the cost.
Maybe it can be called a life-saving diagnostic or something, which I think is easily justifiable for TB, given the very high mortality rate.
Yeah.
Thank you so much. Amir, over to you. So you've done some interesting experiments in Pakistan on social businesses to cross-subsidize TB against more expensive tests, or maybe diabetes or COPD and asthma and other diseases. Tell us how it's been working and whether you see maybe that's the way forward. The TB itself will not be a market that's big enough to sustain, but companies and labs can benefit from cross-subsidizing against other diseases.
Thanks, Madhu. Just to provide some context to what Madhu described as a social business experiment that's going on in 3 sites, Karachi, Dhaka, and Jakarta. This was a grant that was supported by Unitaid, and then with additional support from TB Reach and the Canadian government, and leadership from WHO and other partners, we've been able to set up businesses that are called social businesses. And they're called social businesses because they have a double bottom line. One is you have to make profit to sustain yourself, and the second is that you have to have social impact. And the social impact that we were looking for was to provide free access to the gene expert test in particular, but additional tests related to TB and free treatment for TB in the private sector. In these large urban cities, these mega cities, Karachi has a population of 20 plus million, Dhaka is close to 20 million, and Jakarta again 15 million. So the experience is ongoing. We're about 2 full years into implementation, 2.5 since we started, and we hope to continue into next year, till the end of 2016. The early Excel sheets that I made, I was part of the driving force behind the thoughts that went into structuring these social businesses, suggested that if you were able to do a certain number of chest x-rays, you could use fees from those chest x-rays to subsidize or pay for the sustainability of the operation of these social enterprises, these social businesses. And at this point in time, for Karachi and Dhaka, we are now approaching about 50%, or perhaps have exceeded or hope to exceed 50% by early next year, of operational costs for what we're doing. And what we're doing is large-scale screening in private sector clinics, as well as in some public sector clinics, where individuals are used as either, initially we use them as systematic screeners standing at clinic outpatient departments, screening everybody for symptoms of TB. And that model in Karachi has evolved into referral patterns by GPs to these centers where gene expert testing and x-rays get done. And there, we've screened over 200,000 individuals, 120,000 gene expert tests have been done, almost 15,000 MTB positive patients have been identified, several hundred RIF positive cases. So these are large public health initiatives that have targeted the private sector and then helped us build some sustainable revenue in these social businesses. The effort that you're referring to is, as we learned more and more about what patients are willing to pay for, it became very clear that if you stuck to 2 or 3 additional diseases like diabetes and COPD, which I had originally proposed, you were in fact limiting the revenue stream that you had access to. Because your private sector GP, when he referred your patients to your center, he would order a host of tests, and if you were only offering diagnostics for 2 or 3 diseases, the patient had the challenge of getting some tests done at your center and then having to go to another commercial lab to get other tests done. So the first thing that I learned was, trained as a public health person that I am I the right person to really be the person now implementing this program? Thinking it up was fun, but running it wasn't so much fun. And so we were lucky enough to have, at least in Pakistan, Imran Zafar, who's in the audience here, somebody who came with a lot of background in business and public health business, social enterprises and social franchises. And he has been able to now expand the repertoire of tests that are now available to all of our patients, and those tests are now increasing not just the proportion, the part of revenues that are sustaining our center and our operations, but they are likely to allow us to continue to expand as we go forward. And so I think it's absolutely necessary, as you think about them, not to restrict yourself to a small number of diseases, but in terms of revenue generating streams to allow you to expand to what any other commercial lab would provide.
Thank you, Amir. Very interesting. Janet, a question for you is, Unitate is really all about market-based and market dynamics. That's the DNA of Unitate. But your efforts are primarily, I guess, focused on the public sector, public markets. How does Unitate think about private sector, and are you aware of any market-based interventions that have worked in other disease areas?
Sure. Well, thank you for the opportunity to comment. I think that Unitate has supported projects that have included a private sector component in TB and also in other areas, including the affordable medicines facility for malaria. I don't think we'll have time to go into a full discussion on that, as well as a project with PSI to increase access to rapid diagnostic tests for malaria, also in the private sector, as well as the project, the initiative that Amir had just described. So we're very excited about the potential of engaging in a smart way and maybe creative ways, particularly with the private sector. We heard how important the private sector is. And we certainly recognize the importance of private sector care providers across the areas in which we work and across multiple disease areas. I think we tend to think in silos, and I think that's quite dangerous. It's as dangerous as thinking about the private sector as a monolithic entity. It's not. We know how heterogeneous it is. We know that there's overlap. We know that patients bounce between the public and private sector. Often a patient doesn't know that he or she has TB and is just seeking care, right? So I think that that's something that we're trying to rethink some of our approaches about how to put the patient back at the center of care, and what that means for some of our approaches. Now, I liked what Harkesh had said. I jotted down a note here about finding the win-win-win. And it sounds really simple. How do we shift a high price, low volume market opportunity to a low price, high volume. And that's a fairly simple shift in theory, but then the trick is doing that in a way that we can still ensure quality and access to quality care, that we can ensure sustainability, and this isn't just a flash in the pan, that when the funding or the project runs out, that people, care providers may revert to old behaviors. So trying to figure out a way that's sustainable as well, and then doing that all in a very heterogeneous environment like I just described, and when the transaction costs for engaging with these care providers can be very high. So how do we get to scale? And I think that's something that we have been giving a lot of thought to internally, and we don't have the answer. I think we're very interested. There's appetite within Unitaid for figuring out what we can learn from some of these very interesting projects and how we might be able to take that to scale, how we might be able to realize impact in a way that's sustainable, that still ensures quality, but that is something that is affecting sustained change.
Thank you. Thank you so much, all of you, for such candid and insightful discussion. We do have time for two quick questions, two burning questions from the audience. Sunita.
Thank you, Madhu, and the panel here for the excellent discussions that we had. I'm Sunita Nareddy. I'm one of the private physicians in Hyderabad, India, taking care of TB patients. Just have a question to the audience here, and anybody here. How many private physicians or care providers are there in this group here?
Where?
In this room,
In this room? There
How
was
many
you,
private
there was Zarir.
care providers. Okay. Think we have a problem? I was trying to attend the MDR TB conference for the last few years in India. I kept talking to the state TB program to tell me when there's a program I would like to join, just because I want to understand what the public sector is doing for my own understanding. I didn't get an invitation. There's a kind of a lack of trust mutually. The private doesn't trust the public doesn't trust the private. I think we need to break barriers. I think we need to get more private physicians. If 50% of the patients with TB are being taken care of by the private physicians, why aren't we getting them into forums like this so that they understand what exactly is the latest technology?
Great question. I like it.
A few years ago, the union represented by Dr. Sarabjit Chadha, we met and we were talking in a forum like this about TB, and then we eventually started a project whereby we are working on a software and which improves the notification to the government about all our patients and also monitors their outcomes through the treatment. When we started the project, I thought, forget it, this is not going to work. I'm not going to get any support from my administration. But interestingly, we've been doing this for the last 1.5 years. I mean, the talks have been going on for the last 1.5 years, and the project is in place now for 6 months. I have 100% support from the administration. I think it just needs people to do stuff. And you are the people to motivate more and more people to come into the program and benefit and do more stuff.
Thank you, Sunita. Thank you so much. David.
So I just have a couple comments. First of all, it's interesting how you started off the session talking about how FIDE you've had issues maybe with FIDE negotiating preferential pricing and not including the private sector. So I just want to say a couple thoughts, and then I have a totally separate thing I want to talk about. So I'm going to take a little bit of time, but I've really been thinking about this. So the first thing is, when I first went out to Cepheid, I had to convince them that there was money to be made in tuberculosis. It was really, why should we get involved in this? And what really helped convince them, I think, and in fact, I think I'm the one who can say this because almost everyone who was at Cepheid at the time I came there is no longer working in Cepheid or in this room, was the Indian and the Chinese private market. It was a chance to actually make money on their tests. When I talk to diagnostic people now, they want to know, where the money's going to be. And so I think putting too much emphasis on not being able to make profit out of a TB test is going to be a problem. Now, you could say, well, FIND has already funded 5,000 different people and different groups, and you've seen that beautiful slide that Claudia showed us of the technology out there. But let's be honest, almost all the technology falls into 3 or 4 separate categories. There's the volatile group, there's the nucleic acid group, there's the proteomics group, and almost all of them are in this kind of valley of death of 80% sensitivity, 80% specificity once you actually validate a larger sample. And the real answer to what everyone's looking for here may well be in some technology that is not on that slide. And it's not going to get on that slide unless the people that are doing that work in God knows what field can make money off of it. So I think that that's something that needs to be said. The other thing, though, which goes along with this is that if you look at that slide you showed us about the prices, it could take I would imagine that most diagnostic companies, if they put in a huge amount of effort and multi-million dollars, could get the manufacturing prices, efficiencies, and squeeze other things out of, clone their own Taq polymerase or something, and maybe even cut the price of their assay in half. But if Cepheid cut the expert from $20 to $10, the price of the test would go from 70 to 60. That's a huge waste of effort and investment. That's not where the cost is. So a lot of what you've done has cut down the costs. But I'm wondering whether some research into why these different costs are necessary could in fact ultimately inform ways to get back to the manufacturing product to actually cut down those other costs. For example, I don't know if this is true, but you've got like 3 different kind of central laboratory, peripheral laboratory costs. If the reason it's there is because refrigeration is necessary for storage. If that was a reason for a $20 cost, which is exactly the cost of the whole assay, then perhaps if we knew that in manufacturing, one could put a color dot on the cartridge, for example, that would be scanned along with the cartridge, and if the temperature is off, the test isn't run, and so you'd never have to refrigerate anything because of the 1 or 2% of assays which go bad if they weren't refrigerated. So we need real research into what those costs are, or maybe the shipping costs are so high because you have to ship sodium hydroxide in each package.
Right.
So ship that separately. Or
Sure.
maybe the size of the shipping is, so we need to really research into what is actually making each of those things cost, and which of those things can, with a very small change in the upfront manufacturing or assay design, have a huge effect on the actual cost. So we need to look more carefully at that.
Sure. Thanks. We should close, but Philippe, you get the last word.
Right, just come into
It's
that.
good to have the last word, right? No, I want to share my experience because I've been working in India a lot on this IPACT initiative. And I think, first of all, I have to say that it's been successful. It's never enough, right? And we want to do more than that. But we have already, 110 labs or something like that, and some significant big labs that are using IPACT. And I just want to connect the dot a little bit of what I've heard in different interventions here. To be part of IPACT, a lab has to agree to 3 conditions, right? Not many, 3. The one is when they get a positive, they refer to the RNTCP.
Notify.
Notify to the RNTCP. And this is non-negotiable, right? And that happens. So fine, that's easy. The second one is a ceiling price, okay? Well, this one, let me tell you, there are a number of labs, they don't want anybody to tell them at what price they want to sell the test. So it's not because we sell our test $10 or $5 or $15, they just don't want to play the game. That's the other one. And the third one, which...
Accreditation.
Yeah, it's very important, actually, and I don't think we spoke a lot about that, but this is the quality of the lab, So we need any kind of recognized accreditation of the lab. How many labs in India, in the private sector, have an accreditation?
About 500.
We want to allow the labs that have no accreditation to run diagnostic tests. No. So I think it's a bit more complex than just saying, suppliers, just make it cheaper and it's going to be better. I agree with you. The cheaper is always better, but that's not the only point. I think we have been fighting for the last, 2-3 years to try to get this tax exemption also. Hopefully it will happen one day, but that would be a good signal for everybody. And I want to stress what Renuka was saying here. You know that very well on the TB world, with I would say the three major players on the field, we are all for it, okay? And we are ready to play. We play in India with this concept. We want to expand it to other countries. I think we've always had in mind, let's understand how it can work and impact things in India before we move to other countries. This is something we intend to do, of course. So
Thank you.
To connect the dot.
Thank you,
Right,
Philippe.
thank you, Philippe. Just a quick comment, Philippe. I made it sound much simpler than it really was, and Karthik's job, therefore, is much harder than I made it sound, number one. To David Ellen's point, David, this morning, my team was sitting somewhere and you passed by and someone pointed, that's David. And everyone said, we need to get a picture taken with him. So after this, please, we'd love to have a picture taken with you. But just coming to the point of, we have great insights into the cost, and I can share it with you. It's a $10 test. By the time the laboratory gets it, it's $17. They have about $7 to get everything done for all their operations, for all their overheads, for all their cost of actually conducting a test, collecting a sample, delivering a result. It's $7. And they have about $6 in terms of the profit margin that goes not to one particular lab, but to a number of people within the value chain. And you referred to what would it take to really bring down cost in this, right? And it's very simple. If we could find something that we could place at lower level within the value chain at a POC, and which is why we are very excited about the Omni, that would get it done. Two, just a different business model. As of now, the cost of the platform is about $24,000. Now that, not many labs can pay that kind of money up front, and therefore we've been butting our heads again, Martin and Philippe, for a long time, saying that let's look at a reagent rental model where, right, thank you. Thank you, Wendy.
Wendy
Let's
Stevens
look
is
at
strongly in favor of reagent rental.
Let's look at a reagent rental model, which what that does is, it builds a couple of dollars into the test. It'll go from 30 to 32, but then you suddenly have a larger number of labs that can say, yes, I want it, right? There is certainly risks that are there in that particular business model, but surely, you can put Karthik there. He can figure those risks out as well. So that's
Thank you.
the answer.
Thank you, Harkesh. You were an amazing audience. So thank you so much for staying on, and thank you to all our panelists.